Sir, we are live now. With all your permission, I am starting this session for today.
Yes.
Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Manoj Toshniwal, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD in internal medicine, DM in clinical hematology, and BMT fellowship and consultant hematologist at Jeevan Amrut Hospital, Aurangabad. And today, sir is going to speak on a topic approach to bleeding patients. By taking not much time to know more about the topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
So, good afternoon, everyone here. So, I would like first of all thank you, Doctor, who have joined. I would like to thank you, IGCP Group, for arranging such type of medical talks. Myself, Dr. Manoj Toshniwal. I'm working as a consultant hematologist and BMT physician at Jeevan Amrut Hospital, Aurangabad, Maharashtra. Today, we will be discussing about approach to bleeding disorder or a bleeding patient. Whenever in your clinic or your emergency, someone comes with bleeding, what should be the your approach? So first to know how the bleeding stops, what is the mechanism, that is one must has to understand the basic physiology. Bleeding stops by these three mechanisms. One is vasoconstriction, is platelet plug formation. Third comes the clotting cascade, which activates the fibrinogen to form the fibrin clot. So, initial vasoconstriction, platelet plug formation, and the fibrin clot formation. These are the three steps to which the bleeding inadvertently. If it is not stopping at all, then one of them may be at the problem. That is what we can think of. These are the components of hemostasis. Blood vessel wall, which causes the vasoconstriction. Various platelet-related marker and platelets, they form the primary hemostasis, initial platelet plug, that is closed for long duration by the coagulation factors, that is called as secondary hemostasis. So initially, blood vessel wall causing vasoconstriction, platelets causing primary hemostasis, and coagulation factor leading to the fibrin clot formation, that is secondary hemostasis. These are the factors or components of hemostasis. In first year of our MBBS in physiology, we must have come across this. So how exactly that mechanism happens is elaborated in this. So primary hemostasis is when there is endothelial injury, there is vasoconstriction, von Willebrand factor and platelets come into the picture and they lead to the platelet plug formation. The tissue cells and damaged endothelium gets exposed to the tissue factor, which leads to the activation of extrinsic and intrinsic pathway. This is extrinsic pathway here and this is intrinsic factor here. Okay, so intrinsic pathway and extrinsic pathway get activated, that lead to the formation of oral clot through activation of thrombin, prothrombin to thrombin. It leads to fibrinogen monomer to the fibrin. One more thing which one must keep in mind is that this stabilized fibrin clot gets dissolved by the fibrinolysis, which leads to clot degradation. So fourth mechanism by which patient can bleed is when that fibrin clot is not stable, and that made stable by the factor 13 cross-linking. So sometimes a patient who is having congenital factor 13 deficiency, who has everything normal in this mechanism, platelet count normal, vasoconstriction normal, all coagulation factors normal, that is why PTA-PTT also normal, and still patient is bleeding, it is because of the factor 13 deficiency, which is fibrin clot is not stabilized. So these are the various components of hemostasis. This is clotting cascade through which we go. Okay. So intrinsic cascade is where contact is made with the contact factor, collagen, fibrin surface, and factor 12 starts to activate it. 12, 11, 9, and 9 further goes to 10. And 10 stimulates the growth hormone. Even extrinsic pathway is from factor 7. Factor 7 and tissue factor leads to direct activation of factor 10, and factor 10, factor 2, and then fibrinogen monomer. This is all for the MCQ. This is how the extrinsic and intrinsic pathways work. So common point for both the factors activation is factor 10. Factor 10 is common for both intrinsic and extrinsic. So factor 10 activates the prothrombin to thrombin, and thrombin in turn goes into the fibrinogen to fibrin. Is all. So bleeding disorder, as we have already discussed, usually because of these four parameters being here, there, everywhere. Coagulation factor deficiency, fibrinolytic pathway, vascular disorder, platelet. So let's go by step. Whenever someone has injury, initial mechanism which come into the picture is vasoconstriction. So whenever there is vitamin C deficiency, scurvy, they can have excessive bleeding. Hemorrhagic telangiectasia, hereditary. Usually family have the history. Nosebleed, oral bleed, GI bleed, recurrent iron deficiency anemia. These can be the presenting feature. And some collagen vascular disorder. So this can be the scene where vascular disorders can lead to the bleeding. Second factor comes into the picture is platelet disorders. Whenever there is quantitative problem in the platelet, like congenital thrombocytopenia, Glasgow thrombocytopenia, von Willebrand disease, acquired like drug-induced liver or alcoholism, wherever there is sequestration of platelet in the spleen. So these are quantitative, and when qualitatively they are low, it is immune-mediated destruction, idiopathic, drug-induced, or even non-immune mediated whenever there is DIC, microangiopathic hemolytic anemia, or even leukemia myelofibrosis. These are qualitative disorders of platelet where bleeding can be. Third factor which comes into the picture is coagulation part. Whenever there is congenital coagulopathy, like hemophilia A, when factor 8 is unavailable, factor 9 is unavailable, you can lead to the hemophilia B, one Willebrand or even other congenital disorder. Acquired can be because of the liver disease, vitamin K deficiency, warfarin or other anticoagulation toxicities, or DIC. So this can be the thing you keep in mind when there is history of a patient comes with bleeding. For bleeding patient, this background you should know, and then comes the history of the patient. Rather than directly jumping on the conclusion, history is very important for the patient who is bleeding. First and foremost is the whether bleeding is minor or major. Whether there are just some petechial ecchymotic lesions or someone is bleeding profusely from a wound, bleeding profusely in the joint, bleeding profusely from the gums, it can be. How was the onset? Whether it was spontaneous or whether it was after the injury. That has to be looked into. Third thing to ask is bleeding after hemostatic challenge. If there is some challenge and then only bleeding is there. Whether there is some family history of bleeding disorder, because congenital family history will be there. At least in 60-70%. Then comes specific history, like factor 13 deficiency. All coagulation factors are normal and delayed umbilical cord bleed will be there at the birth. If typical hem arthrosis are there, it can be because of hemophilia A, B, or even factor 10. Recurrent pregnancy loss can be because of the fibrinogenemia factor 13. So these typical or specific history features one must ask to the patient who is coming with the bleed. Family history is important because some are autosomal recessive like other factor deficiencies, Glanzmann's, Bernard-Soulier, other things. Autosomal dominant like VWD or dysfibrinogenemia. And next thing is hemophilia A and B. So first assess the bleed. Second, go for detailed clinical evaluation. History first, and depending upon your history, you need to evaluate the problem. How to evaluate will all depend upon whether what you are looking for. These are various scoring systems from where patient is bleeding, and these are the features or these are the initial workup you do for this patient? Global hemostasis you do by thromboelastography, or for platelet you do platelet count, platelet function study, aggregometry. For procoagulant test you do BWF, collagen factor inhibitor, fibrinolysis also take. These are there. So briefly to understand how to go. First, assess the patient, see whether bleeding is severe enough to go for immediate attention. Take the clinical detail history, then screening studies with CBC, blood smear examination, TT-APTT, bleeding time, and if possible, platelet function assay. If the CBC is abnormal, blood film bleeding time is abnormal, go for VWD, platelet disorder, all those things. If PT-APTT is abnormal, depending upon if APTT is abnormal, you have to look for factor 8, 9, 11, like hemophilia. If only factor PT is abnormal, then factor 7. If both are abnormal, maybe 5 and 10. And if mixing studies are done, if it is getting corrected, it can be lupus. If no abnormality is there, it can be factor 13 deficiency or connectivity or your child abuse. Many a times, this is very important to discuss in clinicians because I get a call for coagulation studies being abnormal. But this is very, very important because usually, if we take EDTA sample and platelet clumping is there, you repeat it in the citrate bulb, pseudothrombocytopenia can be caught. Usually, CBC shows platelet down, but if you see the smear, platelet clumps will be seen, patient will not have any bleeding. Whenever you are doing the anticoagulation tube, use that marker is very important. There is mark on each tube. What is the amount of sample you need to take? 3.2% sodium citrate is there. Up to that mark only you take. One drop more, the test will be abnormal. One drop less, still test will be abnormal. So taking sample properly is very important. Hemophilia is a genetic disorder which is X-linked, usually affect the male, and they present with the family history in 60% of cases. Almost 30-40% will not have family history, and they have typical hemarthrosis. Mild hemophilia is 6 to 15. If moderate is there, 1 to 5%, and severe hemophilia less than 5%. So, mild hemophilia usually they don't bleed unless there is some surgical stress. Moderate hemophilia with some injury they bleed, and severe hemophilia can bleed spontaneously also. So depending upon the factor level, we decide the severity of hemophilia. For detection, usually classical clinical history, easy bruisability early in the childhood, spontaneous bleeding in the joint, muscle, and soft tissue. Excessive bleeding following trauma or the surgery will be seen. Family history will be there in 2/3 of cases, and usually you do the initial evaluation. APTT will be prolonged. You do further test, factor assay, and factor will be less. These are typical hemarthrotic joint for the hemophilia. These are the most common bleeding disorder which we see. They can have the life-threatening bleed also, where they can have intracranial bleeding, neck or throat bleeding, abdominal bleed or iliopsoas bleed. That is why for these patients, whenever they are coming, we need to go by this price therapy, where protect the injured joint, rest the affected joint, ice application, compress and elevate that joint. It helps in initial therapy, and immediately they need to be given the factor 8. If it is available, it is the therapy of choice. If not, maybe cryoprecipitated or plasma can be given for this. For major injury, we do 100% correction. For life-threatening hemorrhages, we give 100% correction. But for other minor things, we give 30 to 60% correction. It has to be calculated with the body weight of the patient, and usually can be given 1 or 2 times in a day, depending upon the injury or how long it has to be taken. It is the clinician decision. Desmopressin is available as a nasal spray. It works only for the von Willebrand disease. Just to quickly brush up, we will go through the 5-6 cases just to understand how clinical history is very important, how the blood evaluation, how to evaluate this patient. So this is 3-year-old baby with excessive bleeding. They come with excessive bleeding. You do the primary workup where INR is normal, APTT, which is less than 6 seconds the normal, that is normal value. Fibrinogen value is 2.3 gram, and normal complete blood count and smear examination. What else on history will you ask about? What other investigation will you order? And what is your differential at this point of time? So, usually we need to ask whether there was some bleeding in previous, whether he needed some transfusion, whether there are some surgical challenges, whether there are some medicines going on, or some family history of bleeding. BWT workup is needed. Factor 13 level, platelet function disorder, endothelial dysfunction, fibrin. These are the various things which keep in our mind. So this was done, and factor 13 level was came abnormal. As PT, PTT both were normal, he was bleeding at the age of 3 years. Factor deficiency was more likely. In this, usually everything is normal, but factor 13 is low, and urea clot solubility is the very easy test where clot is suspended in the 5 urea or 1% monochloroacetic acid. It dissolves within 60 minutes if severe factor 13 deficiency. Mixing studies are needed to rule out inhibitors in old age patients. For these patients where normal, they are bleeding early, and classically the specific history which you will ask is the bleeding on umbilical bleeding will be seen in 80% of cases. Usually, it is inherited, and unless level is less than 3%, they hardly bleed. For them, fresh frozen plasma is the treatment of choice. Let's go for the second case. She is 36-year-old female. History of recurrent abortions are there with associated significant blood loss. No other bleeding history, no family history, not on any medication. You do PT-PTD, both are to the sky high. PT on mixing, normalized. APTD also on mixing, normalized. What are you thinking about? Common pathway problem like 1, 2, 5, 10. Factor were normal and fibrinogen level was very low. So it is common pathway problem, but at the end result, which is fibrinogen formation to fibrin plug. So usually a fibrinogenemia is the condition in which both PT-APTD will be highly abnormal. These are rare disorders, but it is seen. Umbilical cord bleeding is also common in this, as common in the factor 13. Pregnancy loss is a common complication. Females are more commonly affected, and thrombosis are also known in this patient. Let's go for the third case. 62-year-old female scheduled for a laparoscopic cholecystectomy. Normal complete blood count. INR is normal, but APTT came such a high. You will repeat the test, but still it is on higher side. Sample is right. What history will you ask for? Whether there was some surgical challenge previously, bleeding history, medical history, family history, thrombosis history, autoimmune disorder, everything you will ask, and also look for the previous blood work. Factor deficiency can be there, which can lead to the only plate APTT, that is factor 8, 9, 10, 12. Inhibitors, considering her age, may be specific or non-specific. And mixing was done, mixing was normal. So, what are you thinking about? This is factor levels were all normal except for factor 12, and lupus antibody testing was there. So, this is factor 12 deficiency, which is like contact factor. It is associated poor end healing because of the role in angiogenesis. Usually, they don't bleed. That is the classical of factor 12 deficiency. There is always an increased risk of thrombosis. Let's move for the fourth. 67-year-old male with no history of bleeding, present with abnormal INR. APTT is normal. INR is 2.7. You do the mixing study, correction is 3. What additional test you will do? Factor 7 level. Factor 7 level is completely less than the 10. Factor 7 is a rare disorder which presents with the prolongation of prothrombin time. Bleeding symptoms range from asymptomatic to lethal, and menorrhagia is common in 2/3 of people. It is heterogeneous group of mutation which leads to this. So this is factor 7 deficiency. Last case, 39-year-old presenting with easy bruisability and GI bleeding. Past medical history is nil. He works in construction, plays hockey, never had anything. Wisdom teeth extraction, tonsillectomy, no bleeding. Medication is taking thyroid hormone because of the hypothyroidism. Family history is nil. Do routine workup, everything comes normal. But APTT is prolonged and iron is also prolonged. Existing study shows correction, that means no your antibodies are there. So factor 10 deficiency was seen on this. So this is young male, but still there are chances that they may have such type of deposits. This is typical of amyloid. So amyloidosis can present with factor 10 deficiency and bleeding like raccoon. They have often presentation of diarrhea, proteinuria. It is seen in 10% of patients with AL amyloidosis. Binds with the beta platelet structure, and that is why it gets. Let's go for the last case. 22-year-old healthy female present to emergency with multiple lower extremity bleeding or bruising without any trauma. She developed over 4 days before presentation, initially isolated to the field. Everything is unremarkable except she is on OC pills and ecchymotic lesions were seen. These were the large ecchymotic lesions or the lower. You see the peripheral smear? These are classical fagot cells, binucleated cells, or rods, promyelocytes, and this is typical initial presentation of acute promyelocytic leukemia, which is a lethal blood malignancy if not treated, but very rewarding if we can catch them early and treat them early as possible. This month only we have celebrated April 17 as World Hemophilia Day, and because of that only this month we kept this topic, how to approach a bleeding patient. Many a time general public or general physician doesn't know, and it becomes we miss something which is needed and we evaluate something which is not needed. This is how it happens. So for patient who is coming with bleeding, initially take proper detailed history, do the primary workup, and depending upon the primary workup, go by the whether you are dealing with the urolytic pathway, whether you are dealing with vasoconstriction problem, whether you are dealing with platelet-related problem, or you are dealing with coagulation. These are all classical things, but you see the case and judge the case accordingly. This is all from me. Thank you so much for joining in. Yes, Faraz, over to you.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants who have joined this session, sir. Sir, as I can see, sir, we have received some question from the participant. If you allow, with all your permission, shall we take these questions?
Yes, please. Yes, let
Yes, sir. The first question is from Dr. Singhania, and he's asking, how do you integrate evidence-based guidelines into clinical practice when managing bleeding patients?
So, Dr. Singhania, thank you so much for asking such a nice question. Very important question. Evidence-based guidelines actually for all other disorders, I'm not sure, but for blood-related, particularly the bleeding disorders and thrombotic disorder, usual guidelines are evidence-based only because it is just the clinical judgment through which you guide. As to sum up, I am saying that you first see the case, take the history properly, and depending upon that history, you need to judge what evaluation you need, and it keep on unfolding. Till that time, you need to go by your evidence only. So for these patients who are coming to clinic or bleeding, you need to take proper history, do the primary workup, and depending upon that primary workup only, you go as per your evidence. That's all. Thank you.
Thank you so much, sir, for explaining it really well, sir. Moving forward, sir, we have another question from Dr. Srishta Mukherjee, and she is asking, how do you monitor response to treatment in a bleeding patient?
Very nice. Thank you so much. So response to therapy, there are two main criteria or targets which we are looking for. First thing is immediate stoppage of whatever bleeding is going on. If something like epistaxis is there, GI bleed is there, you are looking for the immediate stopping. So you give the treatment, whatever your clinical suspicion is there, and it has to stop. Second thing, we are looking for something like permanent problem solve. You decide what the evaluation you need. You evaluate them. If patient has APML, you treat them for acute promyelocytic. Someone get hemarthrosis, to diagnose them with hemophilia, to guide them to the hemophilia society, arrange them a factor and further care. You see the bleeding patient, you diagnose them with immune thrombocytopenia, you treat them and platelet count picks up. So the evaluation guides the overall treatment response. Two type, one is immediate response and long-term response depending upon the disease entity. Thank you.
Thank you so much, sir, for sharing the insights beautifully. I hope that participant have received his answer. Moving forward, one other question from Dr. Agarwal. He is asking, how do you decide on the appropriate use of blood products, packed red blood cells, fresh frozen plasma platelets in resuscitation?
Yeah, very important question, and thank you, Dr. Agarwal, for asking this, because many times we see, particularly in gynecology, they come across with patient who is actually bleeding, and they randomly advise RDPs, plasma, cryo, and even blood. They transfuse also, and then evaluation becomes difficult because already patient is transfused. First thing, you need to assess clinically whether someone has genuine need of support or not. If hemoglobin is less than 10, someone is bleeding, then only transfusion support is needed. Actually, 7 if bleeding is not that significant. If PT, PTT both are prolonged, you are suspecting coagulation factor deficiency, bleeding is emergent, that time maybe fresh frozen plasma is something which is need to go. You know that patient has some disorder like von Willebrand or factor VIII deficiency, that time maybe cryoprecipitate can be given. You know that patient has acute promyelocytic leukemia and bleeding, that time maybe some thing like RDPs or SDP or fresh frozen plasma is needed. So depending upon your clinical judgment, then only you jump whatever is needed exactly, you replace that thing rather than giving it as a blanket therapy. Thank you.
Thank you so much, sir, for sharing your insight again on this question with your experience, sir. I hope that Dr. Agarwal has received his answer. And Dr. Mukherjee has written, thank you so much, sir, for answering and sharing your points. And thank you once again, sir, for sharing your precious time on our platform. As I can see, sir, there is no more question from the participants. With all your permission, shall we conclude this session for today?
Yes, for us. Thank you all the doctors for joining in. Thank you IGCP group for such a elaborate and good lecture. Thank you so much.
Okay, sir, and hope to see you again with in future also with new topics, sir. Till then, take care of yourself, sir.